His clinical interests include mitochondrial diseases, congenital disorders of glycosylation, ocular genetics, and rural outreach. He is an investigator for multiple clinical trials for new therapies for rare diseases. He is also the program director for the Medical Genetics Residency Program. He currently sees patients at Children's Hospital Colorado. I've seen Dr. Lawson since he first started, he was figuring stuff out. Thank you so much for all that you do, Dr. Lawson, and thank you for joining us today.
All right, thank you all for having me. I'm happy to be here. So as Annika mentioned, I'm a pediatrician, I'm a clinician primarily. I spend most of my time seeing patients in clinic, in the metabolics clinic, in the genetics clinic, and I spend a lot of time working with people, thinking through what are reasonable medical decisions to make for someone who has a rare disease. So I mentioned the topic of this talk to Dr. Vockley. We were at a conference together a couple months ago, and I asked for his advice about what's the best way to approach this talk. So I'll get to that in a minute. I want to emphasize that this talk is for teens and adults that have recurrent rhabdo who are looking for some additional strategies or what might be a productive approach to take for someone that recurrent rhabdo is getting in the way of the things that you want to do in life. It's causing decreased quality of life. This talk is based on discussions that I've had with dietitians, physical therapists, and patients. And so I think of this as a kind of a four-way conversation between the physician, the physical therapist, the dietitian, and the patient. So my goal here is to sort of talk about how to weigh those different factors and have that four-way conversation productively in a way that will benefit you in terms of your quality of life. The big caveat here is that this is not medical advice. I'm not your physician, with a few exceptions. And so the things that I'm talking about are not meant to replace the strategies that you have in place with your doctor right now, but it might start a slightly different conversation if you want to bring that up the next time that you see your physician. So again, I mentioned the fact that I was giving this talk to Dr. Vockley, and he suggested starting with epistemology. So epistemology is the theory of the philosophy of knowledge. How do we know what we know? And the point here is that there are different types of data that we get and different types of data that we act on. And those data sources have different characteristics. So certain types of evidence or certain types of data are more likely to represent truly reproducible phenomena that are reproducible in a wide variety of circumstances. Other types of data that we get might be noisier, and the approach that we want to have is to act on the things that we think are very reproducible, very likely to be true biochemical or medical phenomena in the world, and to act cautiously in the areas where we might be looking at some noise or something that is not truly a reproducible phenomenon in the world. So you've heard from folks that have worked on clinical trials in this area, and anyone who's worked on clinical trials can tell you that the resources that go into that is enormous, right? There's an incredible amount of time and financial resources, and sometimes risk that's taken on by participants, and it's an enormous undertaking. And for that reason, it doesn't happen as often as we would like. We would love to have more randomized controlled clinical trials to figure out what are the truly reproducible things that are applicable to a broad segment of patients and are almost certain to result in benefit. But those resources don't exist, right? Healthcare is already pretty expensive as it is. So we do the best we can. We're using the resources we have. We're trying to apply them and do clinical trials in the scenarios where we think we might be able to come up with an outcome that is truly going to benefit patients. But then a step down from those randomized controlled trials are things like case series, multiple patients that had the same intervention done in a non-randomized, non-controlled way, but at least it's something that has been reported multiple times in multiple different patients in multiple different contexts. A different type of knowledge that we might act on is just a rational approach based on a mechanistic understanding of a disease. So if we understand that fatty acid oxidation is not functioning well, it might be rational to try to find alternative fuel sources for cells that can't use fatty acid oxidation as efficiently as they should be able to. That's a rational approach, but some of the alternative fuel sources that we're going to talk about, those haven't been studied in a rigorous, randomized, controlled way that would be the gold standard of evidence for us to act on. Lastly, there's expert opinion, consensus among the providers, the folks that have been having conversations in this room and out in the hall during this conference. Clinical experience, the experience of multiple patients. Those are valid data sources, right? Those are not things that we should ignore, especially in the world of rare disease, where the randomized controlled trials are going to be few and far between. So I think the goal for working with your physician or other providers is going to be to try to arrive at a middle ground between these two things that are in tension. So if you are only relying on the randomized controlled trials that exist, you're going to be relying on a pretty small number of data points. And for rare diseases, you may need to take different data sources into account, but you have to do that responsibly. And so that would be my goal for working with the physicians, dietitians, other providers that you're working with, is that you pick and choose the places that you're taking these different data sources and you meld them together in a way that hopefully will benefit you. So one of the terms that I really like that is something that I strive for in practicing medicine is the idea of strong opinions loosely held, right? So strong opinion loosely held means that you're not nihilistic about a lack of data. You can make a hypothesis about something that might benefit a patient, and you can act on that, but you have to be very humble, and you have to be able to change your mind. You have to take new data sources into account and be able to hold that opinion loosely in light of new data that comes up. Don't fall in love with just one hypothesis about how these diseases work. So the talk just immediately preceding this was a really great introduction to the point that I'm going to make. And again, that speaks to the value of having multiple different types of providers involved in your care. Specifically for long-chain fatty acid oxidation disorders, physical therapist, a dietitian, and a physician that are all kind of working as a team and are somewhat literate in the ideas that are relevant to these diseases. So exercise is really important, and I know you got that message earlier today, but I just want to emphasize that again from the perspective of a physician. This is one of the things that we can say is almost an unequivocally good thing. If you are able to exercise more, you are almost certainly benefiting your health and wellness in myriad ways. So one of the key points about exercise is that the largest benefits come from starting at the lowest base. So if you're going from completely sedentary to any exercise at all, that has a huge health benefit for you. If you're going from running half marathons regularly to running marathons regularly, that may be a great hobby, But in terms of health benefits, that's not actually moving the needle nearly as much as going from just being sedentary to being able to walk around and do regular walks in your life and carry things, carry your children, things like that. So this is in tension with the fact that exercise is very clearly a risk for rhabdomyolysis for patients with long-chain fatty acid oxidation disorder. So we need to square those two things, that exercise is so important for so many aspects of your health, with the fact that certain types of exercise are going to result in rhabdo for folks with long-chain fatty acid oxidation disorder. So what's the approach? How much exercise is the right amount? So the earlier talk touched on this. In terms of aerobic exercise, the recommendation, which like all recommendations is a bit of an arbitrary threshold, but 150 minutes per week of moderate intensity exercise, ideally fairly spread out throughout the week, is a really reasonable thing to seek out. The nice thing about moderate intensity exercise is that that's a moving target, right? Moderate intensity is different for different people, and you can rely on the signals in your own body that tell you what is moderate intensity. So I'd like to put a slightly different spin on this. What is the right amount of exercise? It's the amount that will allow you to feel safe and comfortable engaging in active pursuits that you enjoy when the opportunity arises. So if you can have a level of activity on a daily basis that will make you a little bit stronger, a little bit more resilient, so that if your friends say, hey, do you want to meet us at the park for pickup basketball? You could say yes without having a big jolt of fear that you're going to end up having rhabdo. Or if someone invites you to go skiing for the day, that may not be reasonable for all patients, but for some people that might be a reasonable target with appropriate conditioning ahead of time. So that's how I think of the right amount of exercise, right? It's the daily activities that you can do that are going to make you a little bit more robust, a little bit more resilient, and improve your quality of life such that you can participate in more activities that you want to participate in. So then the question, what is moderate intensity? So the default categories of activities that are defined as moderate intensity are things like brisk walking, gentle biking, gardening, dancing, doubles tennis. Or I think an even easier barometer would be the idea that your heart rate is up, right? Your heart rate is higher than when you're sitting there, but you're not out of breath, right? So out of breath, not out of breath means that not that you're breathing at, 11 times a minute like you are sitting right here, but you're breathing at a rate where you can carry on a conversation while you're doing this activity fairly comfortably. A couple other barometers of what is moderate intensity, ways to gauge that for yourself, would be the idea that at the end of the workout, you feel like you could do the exact same thing again without too much distress. You could do that exact same activity back to back, and that wouldn't be impossible or even too distressing for you. Another way to judge moderate intensity, and we have lots of great wearables now, and these are really helpful, I think. So 60 to 70% of your maximum heart rate. So a lot of folks in this room are wearing something that will tell you your heart rate right now. Your maximum heart rate is different for different people have different maximum heart rates, but a rough estimate is 220 minus your age. So I'm 40 years old. My maximum heart rate is roughly 180, slightly higher than that, but that's in the ballpark. So 60 to 70% of that might be a heart rate of about 120. That feels pretty comfortable. If you're doing an activity where you have a heart rate of 120, you can carry on a conversation. You don't feel super distressed by that. So I think one of the big mistakes that patients make when I talk to them about how to approach activity in their lives is they get too intense with it. You get really excited about it, you get really intense with your activity, and that moderation piece is missing, and then it's really unpleasant. You might get rhabdo from it. Even if you don't get rhabdo, it's just really draining. It prevents you from doing other things in your life. And then it's aversive, and you don't want to do that. And you go back to the starting point. So I think this is one of the really key points that I want to make, is the moderate intensity piece. Another, I think, really important idea, and this is a hard thing to study, but people are starting to have ways to study it now that lots of people have wearables that measure their activity and their biometrics, is this idea of NEAT. So NEAT is non-exercise activity thermogenesis. So that's everything that you do that's not being completely sedentary, but it's also not a specific exercise or activity. So that can be things as small as chewing gum, tapping your finger. It can be a little bit larger than that. It can be maybe when you go to the store, you don't park in the closest parking spot, you park in a slightly farther parking spot. You take the stairs one flight instead of the elevator. Maybe you set an activity alarm on your smartwatch and it tells you to literally just stand up every 30 minutes, something like that. Those are all examples of non-exercise activity thermogenesis, or NEAT. Those add up. So over time, that adds to your resilience, it adds to your fitness, it changes your body composition. And if you can start to build those habits into your day-to-day life, that doesn't feel distressing, right? But that is gonna result over time in really positive changes. So I'm gonna go through this very quickly because there was a great talk about this earlier this morning, but we know what the risk factors are for exertional rhabdomyolysis. So those are unaccustomed, strenuous exercise, especially with external pressure. So outside of the world of long-chain fatty acid oxidation disorders, my colleagues and I still get consulted on a lot of patients that don't have these disorders that get rhabdo. It's almost always a setting with external pressures on the individual to exert themselves excessively. So those are things like team sports, races, military training, having a new personal trainer. Those things are a big risk factor for rhabdo, but they're also great motivators. So there's a real tension there in terms of how do you approach this scenario where the exact things that can motivate you to develop that capability, that strength, that physical activity, those are also the risk factors for rhabdo. In addition to that kind of external pressure, other things are eccentric exercises. We had a great discussion of that earlier today. Concurrent infection or inflammation. So that's a huge one. If you're sick, if you're inflamed, if you have a virus or something else going on that's activating your immune system, that is not the time to be engaging in any kind of strenuous exercise. That's a big risk factor. Dehydration, hypernatremia, hyponatremia, those are risk factors, and extremes of temperature. That's absolutely certain, both on the cold end, but especially on the hot end. In the event that rhabdo does occur, non-steroidal anti-inflammatory drugs, they treat pain, but they also impair kidney function. So that's a big risk factor for renal injury if rhabdo were to occur, if we're not able to prevent it, and we won't always be able to. And it's not a failure if you have a long-chain fatty acid oxidation disorder to occasionally have rhabdo that needs treatment. So I'm going to talk about a few strategies here. So having established that exercise is really important, that if we keep it moderate, that can be a really valuable strategy, and even more moderate than moderate. If we can just build those small activities into daily life, that can be a really helpful strategy. So Dr. Gillingham is here. I'm going to talk about a couple of her papers. She's one of the few people that has really done those kinds of rigorous studies of folks with long-chain fatty acid oxidation disorders and how they respond to different energetic substrate, different strategies of fueling. So this has been part of practice for a long time, right? To use medium chain triglycerides as a way to bypass the enzymatic blockade that folks with long chain fatty acid oxidation disorders have. But the key for this study is that this is meant to be the specific fuel for exercise. So this is 20 minutes before exercise, getting medium chain triglycerides into the body and having the muscles, as they ramp up their exertion, as they ramp up their energy needs, they're seeking out energetic substrate. The medium chain triglycerides now have entered the body, and that's available as a substrate, as opposed to the endogenous fat that you have that is long chain. So it's just substituting one energetic substrate for another. And what you find is that the levels of ketones are higher in the body, that the heart rate is lower. So the body is successfully using that energetic substrate to provide physical exertion, and that's less stressful on the body, as evidenced by decreased heart rate. So that's a strategy that I think everyone in this room has heard, and probably most people have tried. The issue that we run into for folks is they feel nausea or heartburn or bloating or some kind of GI distress. So that's really the only risk here. But that risk really is a transient discomfort, right? That's something that you can experiment with in terms of different formulations of MCT products, different timing, different things that you're mixing it with. So it's worth it's worth some trial and error to see if you can incorporate this into your strategies around fueling for exercise if you have a long chain fatty acid oxidation disorder. Dr. Gillingham spoke yesterday about a different exogenous fuel source, which is ketones. So the inability to generate ketones from long chain fats is one of the hallmarks of long chain fatty acid oxidation disorders. Dr. Chatfield also mentioned the importance of ketones as a fuel for heart cells. So both for your heart, for your skeletal muscles, if we can get ketones into your body in a way that's tolerable, again, this is not something that is rigorously evidence-based from the perspective of a placebo-controlled trial, but this is something that is rational based on our understanding of these of the mechanisms of these conditions. So this was a study that was done pretty recently with a product called ketone esters. And I think most folks heard yesterday about ketone esters and ketone salts. So this is an intervention where folks with long chain fatty acid oxidation disorders, they either get pure carbohydrates as their fuel prior to exercise, or they get a combination of ketone esters plus carbohydrates. And so having taken that dose, then they get an exercise test. They get really regular monitoring of blood tests during exercise. And then after the exercise, they get a special MRI test that can measure the amount of what's called phosphocreatine. So that's the immediately available fuel for your muscles, the fuel that your muscles can use within seconds and draw on as needed. And that's a measure of the energetic state of the muscles. Are the muscles energetically replete or are they depleted? So importantly, though, I want to point out here, the dose that they used was 400 milligrams per kilogram of ketone esters. There were minimal side effects for these subjects. That's a pretty large dose. This is a small number of folks. I'm confident that if we tested a larger number of people, that you would run into some people that felt like they had some GI distress associated with this. The big problem right now with this, you can buy this product online. It's readily available, but at this dose, it's going to be $20 to $40 per dose. So that's going to be challenging financially as something that you incorporate as part into your daily routines, right? That's going to add up really quickly. So these are a couple of the outcomes that they showed associated with taking ketone esters prior to exercise. They showed that the level of beta hydroxybutyrate, which is the main ketone that we measure in the blood, that rises significantly and it stays elevated for at least 90 minutes. So that's one potential problem with ketones, is do they just enter and exit the body too quickly to use? It looks like they do stay in the body long enough to be useful. The other thing that they did muscle biopsies, which is that's a pretty invasive study, right? So you have to keep when you do a study like this, you have to have a very small number of very dedicated research subjects. But they were able to show that within the muscle tissue, those ketones are being used as energetic substrate. The ketones have gotten to where they need to be. They're actually being used for energy by the muscles. The levels of the kind of diagnostic metabolites that we use, long-chain acylcarnitines, those are lower in people who get ketones as opposed to just carbohydrates. And this special MRI where they measure the energetic state of the muscles have more phosphocreatine. So they're more energetically replete for the people who get ketones prior to exercise as opposed to just carbohydrates. So that seems pretty promising. And again, I'll defer to Dr. Gillingham in terms of a little bit more of the discussion of where this field is headed in terms of ketones as energetic substrate for folks with long-chain fatty acid oxidation disorders. The other thing I'll mention, there's a much cheaper version of ketones that are also available. And these are kind of in the world of performance enhancement, legal performance enhancing substances. So bike riders in the Tour de France, which is ending as we speak, they're taking ketones. They're taking exogenous ketones as part of their fueling strategy while they're riding. So this is available. It's legal. There are both ketone salts and ketone esters, as I mentioned. Now, this study is the only study that I know of that has compared those directly in terms of tolerability. The big caveat is that one of the first author on this study is part of the company that makes one of the ketone ester products. So take that with a big grain of salt. But they did find that they did low dose and high dose ketone esters and ketone salts. They found that GI side effects were higher with higher doses than lower doses, not surprisingly, and that the GI side effects were higher with ketone salts versus ketone esters. The main reason for that may be that there's a large amount of salt that you get with the ketone salts. So you're getting a lot of sodium or magnesium or calcium. Whatever salt that ketone is attached to, that's a pretty big load in your gut. And that may exceed your gut's ability to absorb those salts. The other big problem, and if you choose to consider this strategy, I would highly encourage you to talk about it with your doctor, because I think you'd need some lab monitoring. If you're going to get up to the effective doses of ketone salts, you'd need to monitor your electrolytes to make sure that you're not causing electrolyte problems. So that's something that your doctor would need to participate in and order labs for you. Another topic I want to touch on in terms of fueling is the idea of how much carbohydrate should you be taking in. So one of the lucky things, if there are any, right? One of the silver linings about long-chain fatty acid oxidation disorders is that the same basic science that's relevant for understanding the mechanisms of long-chain fatty acid oxidation disorders is also relevant for exercise performance. And there's a huge body of literature around exercise performance. So again, with this mindset, strong opinions loosely held, using the right data at the right times, I think we can draw on some of the data from exercise performance to look into things that might be rational strategies. So this is a study where they combined no fueling at all before exercise. They compared that to taking in glucose. So something like a straight glucose source would be just like carbohydrate, bread, crackers, things like that, versus sugar, so glucose and fructose. And what they found, so if you look at this graph right here in the middle, that those cross-hatched portions of the, so the total here is 100% of the total energetic substrate that is used by the muscles. The crosshatch portion is fatty acids. So how much energy are your muscles deriving from fatty acids as opposed to carbohydrates during exercise? So if you don't take in any carbohydrates at all, your muscles are using a lot of fatty acids as their energetic substrate. So 70% of the energy use for your muscles is fatty acids. If you take in glucose as opposed to exercising in a fasted state, then it's more like 60% as opposed to 70% of the energetic substrate for your muscles is fat. If you take in sugar as opposed to glucose, that goes down to more like 50%. So the reason for this is that we have different pathways for fructose, which is part of sugar, as opposed to just glucose, which is sort of non-sugar carbohydrates. We have different transporters in the intestine, so you can get more carbohydrate in, and you can use more of it. It shuts down more fatty acid oxidation within the muscles. So consuming glucose and fructose together leads to better exercise performance and less fatty acid oxidation in the muscles. Again, this is in the exercise performance literature, not in the fatty acid oxidation literature. Now, the dose here is this is the thing that I want to convey to you. The dose of carbohydrates that were studied, 54 grams per 30 minutes. That's a lot of carbohydrates, right? So, and there's a lot of research in exercise performance about how much carbohydrate can you take in and how much does it lead to performance benefits. So one of the things that looks like is true from this literature is that taking up to 90 grams per hour of carbohydrate clearly benefits your performance. So these are people on doing bike rides or running. 90 grams per hour, which is a lot, that improves performance. Some people can continue to improve performance up to 120 grams per hour. Other people don't get additional benefit. But the reason that people are not getting additional benefit as they go from 90 to 120 grams per hour is not that they're not using the carbohydrate, it's that they're switching off fatty acid oxidation. So from the perspective of performance, switching fuels may or may not be helpful, but from the perspective of fatty acid oxidation disorders, that probably is helpful, right? To be switching fuels to carbohydrate. So the point being, I would be surprised if many people in this room are concertedly taking in 100 or 120 grams per hour of carbohydrate while they're trying to exercise. So just to give you an example of how much carbohydrate is in different products that people are using. So this is regular Gatorade, not Gatorade Zero, right? Gatorade Zero has no sugar. That's not what we want here. Regular Gatorade per 12 ounces has 22 grams of carbohydrates. So to get up to that, you'd have to consume 5 12-ounce bottles of regular Gatorade to get up to that threshold, which is not possible, right? So there's a lot of companies now have developed products that are used during the Tour de France and other types of endurance activities that have this product right here is 79 grams of carbohydrate that's meant to be in a 12 to 15 ounces of liquid. So that's pretty that's pretty concentrated in terms of the carbohydrate intake. But I think it's rational to think that there may be benefits for folks with fatty acid oxidation disorders of really increasing the carbohydrate intake during exercise. I don't have any financial relationships with any of these products. These are just examples of high carbohydrate sports fuel. So this is really important, right? The body's metabolism changes dramatically when you're exercising versus not exercising. So that exact same strategy that might be helpful for you during exercise, that would be damaging to you if you're not exercising while you're consuming that volume of carbohydrate. So that fructose that can go directly to your muscles and fuel them as part of a strategy while you're exercising. If you're not exercising, that lodges in your liver, causes metabolic problems in your liver. So another study that Dr. Gillingham did, speaking to this point exactly, is that if you're not exercising, what do you want your fuel breakdown to be? Assuming that you're taking 10% of your calories from fat, what should the rest be? And so in this study, Dr. Gillingham and her colleagues just asked people to use a whey protein supplement. That's a widely available product to increase their content of their caloric intake that was from protein as opposed to carbohydrates from 15% to 25% of their caloric intake. So it's a reasonable, easy to implement intervention, I think widely considered to be safe. And it has pretty dramatic effects after just 4 months of doing that intervention. So people who were on the protein supplement had higher lean body mass, meaning they had more muscle tissue, and they had less fat in their liver. So metabolically, they were healthier and had more muscle tissue. When you have more muscle tissue, you have a higher basal metabolic rate. You're using the food that you take in for productive purposes, for allowing you to be active and to move around, as opposed to storing that as fat in your liver and elsewhere in your body. So again, it's a completely different mindset during exercise as opposed to not during exercise in terms of where you want your fuel to be coming from. So integrating this together, increasing daily physical activity is a very important intervention to improve health and wellness, especially for those with lower activity levels at baseline. Activity snacks, so that's another term for the NEAT or non-exercise activity thermogenesis, and relatively low intensity exercise can really add up and have big benefits over time. Finding the right mix of activities is going to be individualized. It's going to be a long-term trial and error process. I think another takeaway that I would have for you is that what gets measured gets managed. So they're pretty cheap and readily available now to have a watch that follows your heart rate and follows your activity level. That can help with motivation. That can help with a sense of progress. It can help you to identify the right intensity of exercise, which I think for a lot of people, it's just too high. Social and group activities can be really motivational, and they can be a great strategy, but be careful with external pressure about the intensity or duration of exercise. Exercise tolerance for folks with long-chain fatty acid oxidation disorders may be improved by consuming more carbohydrates, and I think maybe a lot more than you think during exercise. MCT oil and ketones before and during exercise, those I think would all be reasonable things to do, with the big caveat about ketones that it's early days. And I would want you to make sure that you're involving a physician, especially if you're using ketone salts. GI side effects may limit the doses of all three of those interventions. But there are many different preparations and products that you can try that might work for you. Again, it's worth this kind of trial and error approach because the end goal is that important. Outside of exercise, consuming a protein supplement may increase lean body mass and decrease liver fat for folks with long-chain fatty acid oxidation disorders. And that's the flip side of the coin. The same things that you want to be doing during exercise are kind of the opposite of what you want to be doing outside of exercise. And the big important point here, all of these considerations are in addition to avoidance of fasting, getting lots of physiologic support during illness, caution with temperature extremes, as well as all of the other long-chain fatty acid oxidation disorder care that's prescribed by your physician and the rest of your team. All right, thank you all. Dr. McGuire, I think you're up. Yeah.
So how long
Yeah, so in terms of like a high carb fueling strategy, that might be like within a window of like 15 minutes prior to exercise and throughout exercise. Yes. Correct. As part of your daily food intake, like taking protein during exercise, there's some studies about that, but I think a better strategy to focus on carbohydrate intake during exercise. But outside of the time that you're exercising, increasing your protein intake, I think, has the potential for many people to lead to beneficial outcomes. Yeah, so the data that we have is going from 15% of calories to 25% of calories was shown to have beneficial effects for protein. Yep. Sure. Yeah. 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 Yeah, I think just, really trying to get a lot of carbohydrate intake, more than you think, during that window, during and immediately after exercise. I don't have an exact number, but maybe up to an hour after exercise, you're kind of in that window where your muscles are asking for more energetic substrate. They're asking for fuel, and if you can provide that with carbohydrates, your muscles aren't going to try to get as much from your endogenous fat stores. Yeah, so like 90 grams per hour throughout, starting immediately prior, through exercise, and then, yeah, continuing maybe an hour after exercise. Again, this is going to have to be in the context of the bigger picture of your total caloric intake, making sure that you're working with your physician, your dietitian, your PT to balance all of these things. But most people I talk to, I think, are significantly under fueling during exercise.
Thank you, Dr. Larson. And thank you for clarifying with that too, because I think that was like a game changer for our family when we talked to an exercise physiologist, and he reminded us that your body's still going even after you exercise. And I don't think we all often think about that your body's still using all that energy. So thank you so much.